This work entitled Progress Toward Triple Elimination of Mother to Child Transmission of HIV, HBV, and Syphilis, which was a 12-month retrospective analysis of the testing coverage in antenatal care clinic in Cameroon. I'm sure we all know about the triple elimination concept and the initiative and WHO agenda. What I will say is that in Cameroon, the Ministry of Health committed to reduce the vertical transmission of the three diseases, HIV, hepatitis B, and syphilis, in its 2022-2030 National Strategic Plan. And the goals include reducing to less than 2% the number of mothers living with HIV who pass the infection to their babies by the age of 4 to 6, and to less than 5% by the age of 18 months. And just to say that currently it is 5% and 80% respectively, 18% respectively, as per the recent NAC report. And for the HBV is to reduce to less than 1% the infection, and for syphilis, less than 0.05%. While the government is committed to do that, there is a paucity of data on the prevention of vertical transmission of these three diseases in Cameroon, and particularly for HBV and syphilis. This is why we conducted this study to assess the testing coverage, vertical transmission of HIV, HBV, and syphilis, and also the factor associated to this trend among women attending antenatal care clinics. We retrospectively abstracted data of a cohort of pregnant women seen at first ANC between October 2020 and September 2021 in 15 high-volume health facilities supported by ECPAF in Littoral and South region of Cameroon. The data were abstracted from source documents in the facility, mainly the facility register found in ANC, post-ANC, labor and delivery, the cohort monitoring register, and we triangulate also in pediatrics and neonates register. And also we check pregnant women medical files for those who gave birth at the facility. In this source document, we abstracted data on women's demographic, the testing at ANC, especially HIV, HBV, and syphilis, and also the result of the testing. And for the infant born in the same facility, we check data on testing when existing and data on prevention. Analyzing this data, our primary outcome for pregnant women was to estimate the proportion of women tested and testing positive for HIV, HBV, and syphilis, and also identify the factor associated with being tested and testing positive. And for children, it was the proportion of those tested and confirmed positive for the three different diseases, and also the access to prevention. These are our results. From October 2020 to September 2021, 21,419 pregnant women attended the study facilities for their first ANC, and among them 99% were tested for at least one of the three diseases targeted by the Triple Elimination Initiative. And from these 21,000 women, 8,799 completed the follow-up in the same facility and gave birth to 8,903 children. So our study population is made up of 21,419 women and 8,903 babies. This table is to show the demographic of pregnant women enrolled in the study, and just to say that there was no clinically significant difference between those who completed the follow-up and gave birth in the same facility and those who did not. Looking now at the testing cascade, we can see on this graph that the first cascade is the one of HIV, and 98% of women who attend the facility for their first ANC were tested for HIV. And among them, 807 tested positive. But just to mention that 600 among these 800 were non-positive. And the overall positivity for HIV was 3.9%. And from these 807 women, 89, almost 90% were initiated on ART. Looking now at the HBV cascade, we can see that only half of pregnant women were tested for HBV. Of course, we know from an unpublished study conducted in Central Hospital in Yaoundé that this gap is mainly due to financial barrier. And among the women who get tested for HBV, 3.7% were positive. And we have the documentation of the hepatitis treatment for one woman who was mono-infected. When I say we have the documentation, it is important to clarify that most of the time, at this time, the hepatitis treatment is given by a pathologist in specific referral hospital, and it is possible that some of these women received treatment, but it was not documented at the ANC where they were followed, or out of the 15 facilities. But what we have documented in facility is one woman who get tested, who get initiated for hepatitis, and 21 other women who was co-infected with HIV obviously received the treatment, the hepatitis treatment. Looking now at the syphilis cascade, we have a similar trend with almost 60% of women who received the syphilis test. Among them, 1% tested positive, but we did not have documentation for the treatment. Not because the treatment is not available, the treatment is available, but it is not free of charge. Women have to pay for it. And most of the time, this treatment is documented in the patient booklet that the woman keep with her because she can go in any type of facility for the follow-up of her pregnancy. So the healthcare worker usually document it in the patient booklet and not necessarily in the register, unfortunately. So looking at the co-infection with the three diseases, we can see that 9,564 women out of the 21,000 were tested for all three infections. 21 of them, as I already said, were both HIV and HBV infected, and all of them were initiated on ART treatment, treated for the two diseases. 6 women had both HIV and syphilis infection, and 8 women had both HBV and syphilis infection, and none of them had all three infections. Looking at factors associated with testing first, we can see that the number of ANC visits is a key player. Women who attend at least 4 ANC visits has an increased odds of getting tested for syphilis and hepatitis B. We also see that women living in South region had an increased odds of getting tested for these two diseases, syphilis and hepatitis B, as well as those who completed the ANC visit in the private or faith-based facility. To be honest, we are yet to conduct a qualitative study to understand what is happening in the South region and in private and faith-based facility. Probably there are some good or best practice that we can learn from these places. And, but we know that we should encourage women to do their ANC visit, because the more we remind them to do it, to do the test, the more they are likely to do the test. Looking now at positivity, age and marital status were associated with HIV positivity. Women aged 25 years old or older were more likely to test positive for HIV. Looking at HBV positivity, the HIV status, the positive HIV status, increased the odds of being positive to HBV. And for syphilis, we noticed that living in a rural area increased the odds of testing positive to syphilis. And we think that there is a link with the South region, which is majoritarily a rural area, and we really need to explore that with a qualitative approach. Coming now to our children population, as I said, we have 8,903 children born to the mother who complete their pregnancy in the same facility. 446 children were born to mother living with HIV or were exposed to HIV. And among them, 264, 59%, had their final HIV status determined, and the transmission was 4.5%, which is almost below the target of the MOH, which means that this target is feasible, and it's just to increase the work and to meet that target. 197 children were born to women with HBV, and 4 of them received immunoglobulin. 7.5% received the first dose of HBV at birth, and 67% received it as part of the expanded immunization program. Among the 61 children who were born to women with syphilis, as I said, we did not have documentation of the congenital syphilis in the source document that we consulted. So what are the key messages? First of all, only 44.6% of pregnant women coming at ANC were tested for all 3 infections, which means that we still have a 50% gap, which is really important. The positivity to HIV is 3.9%, 3.7% for HBV, and 1% for syphilis. We have a transmission of, a vertical transmission of HIV of 4.5% at 18-24 months. And we have an important gap of information regarding treatment of syphilis among pregnant women, and also diagnosis of syphilis among children. The same for hepatitis B. In conclusion, I will say that despite the considerable progress made to prevent vertical transmission of HIV, significant gap remain in delivery of service to prevent vertical transmission of HBV and syphilis, particularly for testing and prevention, as well as treatment of exposed infants. Integration and documentation of subsidized hepatitis B and syphilis testing and treatment for mother-baby pairs is critical for child survival. I will not end without thanking all the facility staff who contribute to collecting this data, the Ministry of Health, CDC, PEPFAR, and ECPAF country and global teams. Thank you.